So out of curiosity, how many of you guys are currently working at a practice that is age friendly? If you could just put yes or no, so we can just kind of see where everyone's at with already working somewhere with age friendly. Awesome. Lots of yeses. That is great. So we should all have a pretty good understanding of age-friendly care as we go through. So as far as the objectives today, really identify opportunities to enhance medication, mentation, mobility, what matters, and multi-complexity across the continuum. Identify healthcare disciplines that can help close existing gaps in access needs of older adults and caregivers, and analyze how innovative care models can provide expanded access points. So first thing, we're just going to start talking about healthcare in general. So our healthcare system is very complex and overwhelming. So think about how our clients and their caregivers feel. They often have no idea the difference in the different settings and even the difference in the many different healthcare professionals out there. How many of you can confidently say you are well educated and know the difference in all of these different settings? If you can put a yes or no, and it's fine if you put a no, because I'd say the majority of people are probably a no, if we're truly confident or answering correctly, right? So, think about the screen here so I can see. So we think about a loved one, and I've had a few different friends and family reach out to me recently with their loved one in the hospital and so confused about what to do. And they're like, Kara, they're telling me that I have to take him home. He can't even walk. What's going on? And they're talking about like transitional care unit versus a swing bed, and they don't understand the difference. Well, what we find is that healthcare professionals often don't understand the difference, and they may not even consider how recommending someone to transition from, say, home health might impact someone differently than if they were recommending they transition to an outpatient in the home program, or if they recommend they transition to a swing bed. Also, even if we can identify all of these different types of settings, do we truly know and understand the difference in these settings so that we can articulate it to families, so that our families that we're working with and their caregivers, or our patients and caregivers that we're working with, so they can make the best decision for them? Also, are healthcare professionals really able to make an unbiased referral to the best place? Or is it based on politics? Across the country, we're seeing that many healthcare systems and even other healthcare professionals aren't recommending the option that is most likely best for the client and family because of politics. They're not supposed to refer outside of systems. And as we start talking through the other slides today, we're going to see that there is more than enough clients and people that need services that aren't getting them than there are providers, right? So how can we change this and come together and all work together to best serve our clients? An article by Bombach and Sutherland, and this is a pretty good article. I'd encourage people to check out. It's in the references. In 2022, they note a key being that healthcare professionals familiarizing yourselves with the variety of care settings that older adults inhabit can really help facilitate a safer transition and help reduce, rehospitalizations by them themselves understanding the level of care and adjuncts that are available. So for all of us, in order to provide the best care for older adults and caregivers, and in order to meet the 5 M's, it's really critical that we all know and understand all of these places and the services they provide and how they are different. And the other thing is there's so much that goes into it, right? Like like maybe home health care might be the absolute best choice, but maybe they don't have Medicare, traditional Medicare Part A. Maybe they have a Medicare Advantage plan and the coverage and the payment isn't the best. So there's also that financial piece that comes into it that sometimes impacts families' decisions and so forth. So there is a lot to know in all of these different settings. And we also find that maybe you know what home health care is or what hospice is, but we're really seeing that there's a lot of difference between every different home health company and every different hospice company and every different outpatient in the home. You know, we're all different. So in your area, it's really important to be educated and understand the differences and what they offer so that we can help our clients and families, you know, get the best care that they need. And it's also not just the healthcare system and all these different settings. It's also understanding the different professionals. After attending like the American Geriatric Society conference, the GSA conference, it was really eye-opening to me, the apparent lack of understanding of the different disciplines. And again, I'm an occupational therapist, so let's face it, how many people besides you occupational therapy professionals that are on here truly know what occupational therapy does? If you feel you 100% know and understand what OT does, put an yes. If no, put a no, because I still find that people have no idea what we do. One of my husband's a psychologist. One of his colleagues who is a psychologist literally recently mentioned that, you know, we help people with jobs, right? And I'm like, oh, yeah. So there's still a lot to learning still a lot of learning to do about what the different healthcare disciplines do. And I also say, like with OT, we kind of do a disservice in the fact that we cover pediatrics to geriatrics and everything between. So one OT is not going to be the same as another OT. We all specialize in different things. But when you're working with older adults and caregivers, you know, I really encourage you guys to reach out wherever you're at and try to find and research and find different professionals that will help or that do specialize in geriatrics, because it's more than gerontologists, physicians, social workers. There's a lot more people out there that can really impact and improve the quality of life of our clients and help us meet the 5Ms with that. Now, with the complexity of the healthcare system and all of the different types of facilities, locations, and healthcare professionals, there are numerous transitions that occur. And I know you guys had a recent ECHO session on transition planning and so forth. And how many of you guys feel that transition planning goes very well in the area that you're at? Yes or no? Just to get an idea here where you guys are at. So we do have a yes, that's good. Because transition discharge planning is a huge issue across the United States. Lots of research out there telling us what most of us already know, that it's not good, right? That people are being discharged home too early. I've gotten a call at 7:00 at night from someone in the rehab that I have no idea who they are, not knowing what to do because they're being told they have to be out tomorrow. You know, it's just not going that well, and the statistics, you know, really show it. This article and this quote is specifically about hospital discharge planning. You know, and they note that 1 in 5 patients experience suboptimal or unsafe care around hospital discharge. You know, so it's a huge area that we need to address. And I'll give you an example. I had a client with a cognitive impairment that went to a doctor's appointment. And for whatever reason, the caregiver did not go into the actual appointment. It was not until I saw the client more than a week after that we discovered she was prescribed medications at this appointment that she never filled, because she had no idea that she was prescribed medications once she walked out that door. There was no translation to the caregiver. Yes, they updated the patient portal, but the client couldn't get into the patient portal because of cognitive impairment. So again, we need to look at all transitions after an appointment. What happens? Does that person actually get home, understand the information? Are they able to get to that pharmacy, get the medications, and then take it? So it's not just transition planning from one site to the other. And when we talk about transitions, we often talk about it from the frustrations of healthcare professionals, or at least we do, because we face this all the time with, transitions. Once someone goes into the hospital, we know they're going to try to get sucked into like the healthcare system versus coming back with us, even though we've been with them forever. So it's nice to look at some research on, what the actual patient and caregivers' experiences are. And this article are themes that are based just on patient and caregiver experiences in care transitions. And the four major themes were uncertainty about the new care setting. They have no idea what to expect in these new places. They're not getting educated or told about what's going to expect in these new places. They're frustrated about disruption to daily life and routines. Importance of continuity of care. Patients want the same providers. They want consistency. They don't want to repeat the same thing multiple times. One of my favorite stories is actually a client that actually fired a primary care provider because the primary care provider told them they couldn't continue with us because they had to go with the therapist in their system. And they're like, no, we don't, And again, we can all work better together and serve so many more people and improve the care that we're providing by coming together. And then need for emotional and practical support. They need that reassurance, guidance, and resources. And then think about our older adults with cognitive impairment, that aren't remembering. And then their caregiver also has cognitive impairment. So how can we come together and, really improve care transitions in all different areas? And then another thing I want to talk about that I think we all probably know is that, the US healthcare system is over capacity already. The demand of care already exceeds the system's capacity, which is leading to fragmentation, inequity, burnout. We're facing shortages. Our rural, low income, underserved communities aren't getting the services they need. And then this can lead to medical errors, higher spending, poor outcomes, burnout. All of these things, and then that cause our client, our older adults and their caregivers not to get the services that they need to best support them. And then when we look at older adults, I also want to just look at some statistics about the care that they actually are getting. So research shows that older adults receive 50% of recommended care. Current quality measures miss what matters most for aging adults. Social, psychological, and functional needs are rarely assessed. Fragmentation and lack of person-centered metrics leads to poor outcomes. In an article by Luo et al., they talk about detection rates of mild cognitive impairment in primary care. Now, this was a large observational study, but they discovered that only 8% of expected mild cognitive impairment cases are actually detected in primary care, which obviously is over 90% go unrecognized. And we have people in the community that can help mitigate this, can decrease these numbers if we all, work better together. And if people know the services that are out there to help improve the detection of this mild cognitive impairment. Also, it's important to know that up to 1 in 5 people with mild cognitive impairment may revert to normal cognition. Um, so if we can detect MCI sooner, then we can do treatment to hopefully help them. But then we can also kind of be with them down the line, right? Because we know that they, are at higher risk of later decline. Another statistic, increased risk for dementia. The Surgeon General's advisory indicates that loneliness and social isolation are linked to nearly 50% increased risk of developing dementia. So when we talk about the home and community-based services, we'll talk about how getting into the home, getting them connected with the community can really help with this loneliness and social isolation that we're seeing. Um, the Alzheimer's Association has put out this information talking about how primary care physicians report that they are often uncomfortable diagnosing dementia and answering questions, and that they have received little training. You think about primary care providers, how busy they are, how many people they need to see in the day, and that's a lot. So how can they work with people in the community who are trained that can assist with working with people that are diagnosed with dementia? And then I don't know if you guys have heard, but this is a good article to check out. It was posted a year ago, but it's an article titled "Warning from Older Adults: Care for Aging in America Needs Urgent Rethinking." We see a lot of articles out there about what we as healthcare people think about what's going on. This one is actually from older adults, and they're voicing that they are dissatisfied with care. 82% of older adults say the US healthcare system is not prepared for the growing and changing needs of aging adults. And I think, a lot of us may feel that as well. I have older parents. It's a struggle. I'm 4 hours away, and trying to make sure they get the care that I know they need is tough. And this is also from that same article. 94% say it's more important to maintain quality of life than simply to live as long as possible. So what can we do to help them have that quality of life? They mention in this article that 58% say providers ask about what matters most to them. And those of us that do age-friendly care, we know that should be the number one thing that guides what we do each and every time we see them. 52% of Medicare beneficiaries see 3+ physicians per year. Half of the older adults say their primary care provider does not coordinate with other providers. And again, this isn't necessarily on primary care providers. Our primary care providers are maxed out. They're so overloaded that how do they coordinate with others? And then 56% find the system difficult and stressful to navigate. So I see this more and more now that, my parents are of that age, trying to help them. And then I get calls frequently from friends and family dealing with the same thing. And then last but not least, we cannot not talk about the caregiver crisis, right? There's clearly issues impacting the healthcare system. And not only as healthcare professionals we're seeing it, but also the older adults. But then another huge issue is the caregiver crisis going on. And 63 million American adults provided ongoing care in 2025, which was up 45% since 2015. And this is just expected to continue to increase. And with these numbers, there is research out there on ways to support reducing caregiver hours. And this is just one tiny example. But did you know that home modifications, now I need to stress that it's not just any home modifications or any home assessment. It actually needs to be done by a therapist that's skilled, educated in home safety, and we recommend utilizing the HEART protocol and so forth. But if if we can get in there, do a home safety assessment with appropriate follow-up and appropriate modifications, it's been shown that we can actually reduce the amount of caregiver hours, and they found it to be up by 6.32 hours a week, which is pretty huge, right? But how many referrals are made for home safety assessments? Do you guys see in your area that there are a lot of occupational therapy professionals doing home safety assessments? And if you could put a yes or no. And if they are doing home safety assessments, are they skilled and trained? Are they doing follow-ups, or are they a one and done type system? And home safety assessments not only help to reduce caregiver needs, but a study that was done recently show that they can also help reduce falls by 38%, right? So lots of great things that are going on out there. But yeah, like Kayla said, they are completely overwhelmed, not as many as they should be. But again, we're not utilizing our systems, right? There are people in the communities that can help and do a lot of this stuff, but we all gotta put different systems beside, we work for different people aside, and all come together and work together, and we'll be able to help so many more people out there. And I could do, a full day training just on home safety assessments. The research shows that with a home safety assessment, one, you have to have the education and training in home safety. The research is showing that assessments completed by other professionals don't demonstrate the same evidence-based outcomes as occupational therapy professionals. And then the research shows that there should be follow-up, and we're finding that a lot of time there's no follow-up. It's like a one and done. But research stands behind that there's, 2 to 3, maybe 2 to 4 sessions initially, and then there's, you're coming back, in 3 months, you're coming back in 6 months to make sure that things are set up appropriately. And then, of course, we got to talk a little bit about medication, and medication's a nightmare. Does yes or no, medication management, how our older adult populations are taking medications? Do you feel that is going well, or is it not going well? Yes, if you feel it's going well. No, if it's not going well. I myself, let's face it, I really kind of stink at it. My husband, he's going to kill me for saying this, especially since some of you might know him, but just to give you an example that it's not just older adults, but my husband, he would just take his medications with no water. Seriously, like he caused an ulcer, you guys, in his throat. So it's not just older adults that are impacted, it's everyone. So out of 119 patients after hospitalization, 79 needed new medication. 87.4% received instruction for new meds. Only 66.7% got guidance on combining with existing meds. Between 40 to 75% of older adults in the community don't follow their medications routines. Do you follow your medication routine? I can tell you right now, my morning was so busy, I didn't follow my medication routine. But this is a huge issue. We recently had a client, when I went to do the initial eval, had 25 medication bottles on the counter. He's been in and out of the ER with the new medication every time, and no collaboration between anyone there. You can imagine what's going on with this person and their overall health, right? So it's a huge issue. And there's more people that can get involved to help improve this and make it better, and which we'll be talking about coming up. Okay, so we talked about healthcare is kind of a disaster. We talked about there's a shortage of all of us. We talked about, some stats with mild cognitive impairment not getting diagnosed. We talked about medications not being managed well. People are falling. There's just lots of things going on out there. And now we're going to talk a little bit about traditional healthcare and why we kind of have to think above and beyond traditional healthcare. So I'm guessing everyone is pretty understanding of what home healthcare is. I would guess this is probably the majority of yes, but do you feel like you fully understand what home health under Medicare Part A is? Yes or no? Just out of curiosity. Awesome. So I was guessing that's probably good. So since I'm an OT, I'm just going to use OT. Now you got to remember that the statistics and stuff I'm showing you is based nationally. So it doesn't mean it's based to your area, my area, or anything like that. Okay? And there's things that can kind of skew the numbers. But we're going to use OT as an example. How many OT visits do you think on average a patient on home health gets? If you can put that number in the chat. Yep, per week. Let's do per week. Okay. Okay, so according to CMS data, the average number of visits per 30-day home health episode, and this is from 2023, but I will tell you these numbers are actually decreasing. And I work with therapists across the entire United States, and I hear it from therapists all the time. In a 30-day period, OT isn't even up to one visit. Okay, so definitely not one per week. Now, your home health in your area, maybe the OT goes out 2 times per week. But overall, just so you have an idea of the healthcare system in general, these are some numbers. Skilled nursing, 3.86, PT, 2.78, OT, 0.7, speech language pathology, and then it gets, it declines as we go. And they're actually, I don't know if you guys pay attention at all to the numbers. There was supposed to be like I can't remember if it's 6.2 or 6.4% reduction in home health coming January 1st, but it's only like a 1.2 or 1.3. But what they're finding is that the profit margin of home health care agencies is up in the 30%. I can't remember the exact amount. I'd have to look back at my data, but they're finding that, the profit margins of home healthcare agencies, some of them are up a little higher, right? So they're like, well, they have these big profit margins, so we're going to reduce the number of money that they get. Well, the problem is you have home health agencies that are awesome, right? That they're providing the services that are needed, but then you have other home health care agencies out there that are maybe not providing the best services. We actually just had someone reach out a couple weeks ago that found out that they were contracting with a very fraudulent type of home health care agency. Again, nowhere around me. But there's things like that go on or out there that end up impacting all of us, and and making things more difficult. But in some areas, they're not able to provide the services that they really could in order to provide the best services possible. Like we look at OT, they're lucky to get in there 45 minutes one time, and I just mentioned that if you're really looking at evidence and the research supporting, just the home safety assessment, that alone should be more than one visit that you're in there. And then we look at PT and their lack of visits, but yet we know that PT plays a huge part in the mobility side of things, right? As well as in the what matters and all of those other areas as well. Anybody shocked by these numbers or any Just curious if anyone was familiar with what these actual numbers are. Anyone? Yeah, it's crazy. So, now let's talk about primary care provider visits. Okay. Out of curiosity, how much time do you guys think primary care providers spend with someone during a visit? Let's start with that number. So when you go see a primary care provider, how much time do they spend? What's the average? Okay, you guys are pretty much right on. Um, any any idea we're going to shift? What's the average time that a primary care provider spends with one of their patients in a year? So we're switching to a year. Okay, you guys are pretty right on these stats. So again, we work with a lot of primary care providers. They're amazing. But they do get pretty maxed out, right? The system isn't always the greatest as far as allowing them to spend the time that they want and need with their patients. So this is average primary care consultation times. It really depends on the type of setting and so forth. Those with mental health disorders, there's large variance, older adults between 10 to 30 minutes, chronic multimorbid conditions, a little higher. But really, when you look at the numbers, the standard 10 to 15-minute visits are really insufficient for the high need population and our older adult population. Um, just because I kind of like to look at how we compare globally. This is just some global variations. I found it interesting that in Bangladesh, 48 seconds, all the way up to 22.5 in Sweden. So again, there is extreme global variation. Many health systems, allocate really too little time for this. But again, a lot of it unfortunately goes back to money. Unfortunately, and as well as also trying to get as many people in as possible in order to get people at least in. Um, this was, oh, this isn't gonna pop up, darn it. Um, so this would be a good graph to show. I'm not sure why it isn't showing, but this article reviewed 150 studies and 7 tropical clusters, and it shows the average number of visits and contact time. And we're at about that 60-minute mark per year here in the United States. See the graph on one screen, but I can't see it on another. Shoot. Again, I think we probably all know longer consultations are associated with higher patient satisfaction, better shared decision making, and so forth. So we pretty much probably all know what the impact is with that. Okay, hospitalization. I mean, some of these numbers I was shocked on. And again, we all have to know that this is very variable and it's, takes a lot of different places into account. But out of curiosity, what do you think the average amount of rehab an older adult receives when they're hospitalized? Let's just do minutes in 1 week, just to make it easy. How many minutes of rehab do you think someone gets in the hospital? Okay, you guys are pretty darn good on these numbers. I just continued to be shocked with some of these numbers. So um, the article looked at the average amount of rehab older adults receive during hospitalization, and they found that they averaged 61.3 minutes per week. Older adults are at an extreme risk of hospital associated disability. Over 1/3 develop a new major functional disability during hospitalization, and many do not recover to baseline even 1 year later. Um, And this decline in mobility drives nursing home placement, higher caregiver burden, increased hospital and post-acute care, mortality. I will tell you that we have actually brought people home earlier from the hospital just to get them home and get them going and moving faster, because all they were doing is, being, were laying in the hospital and they were declining. Um, so yeah, just kind of interesting stats there. Unfortunately, I didn't go through all of the other different types of settings. There are a lot of other settings that we could look at the numbers and so forth. But now I want to shift a little bit to non-traditional settings. And in other parts of the country, we are seeing a lot of more concierge type practices, private pay type practices, different models. And just more and more things are coming up. And the one that I want to focus on is really the one that I obviously know best, because that's what we do and what I help people do across the United States, is really the outpatient in the home. And again, we're finding that this is something that you really can't compare one outpatient in the home clinic to another outpatient in the home clinic, right? Because we're all set up a little different with that. So who in here is familiar with the difference between outpatient in the home versus like home health under Medicare Part A or traditional outpatient? The yes or no there. So we have a lot of yeses, lots of nos. Awesome. Okay, so outpatient therapy in the home, has actually been established in reimbursable service for, you know, I'm not going to say forever, but it's been for a long time. Really, it's really picked up since COVID. I remember way back when I worked at Altru, we got this started in several of the different assisted livings and so forth in the community. Again, going out to the person's home when you're in a big healthcare system isn't the most financial beneficial thing, because when you see people in an outpatient clinic, you can see people more. It's more time effective. You can reach more people. There's a ton of people that actually need outpatient therapy in a clinic, and then driving to people's houses. You don't get paid for that and so forth. So it can be harder and not the best model for some of these bigger healthcare systems to do, but it's a great model for private practice owners that really want to start a business, that are really passionate about working with older adults, and can be a great model for them to do. And, a lot of people still don't understand everything about it. They think that people need to be homebound. They think that they have to have a doctor's order first. There's just a lot of different things that people, really don't know and understand the difference. Also, when you're out there, some outpatient in the home, their goal is to see people a few times and then get them into a clinic type setting, versus some are truly there to see the person in the home long term and so forth. So some key differences with, there's no homebound requirement. Therapy services really range. A lot of the private practice owners that own outpatient in the home businesses, usually see clients 2 to 3 times a week, but that number is going to depend, because it needs to be based on what clients actually need. I mean, we've seen people 5 times a week if they need it, so it's going to be based on what they need, versus, like with the home health agency, again, you sell the numbers. They're not going to be able to see someone 5 times a week. And a lot of the different home health companies would probably not allow that. And then another thing that a lot of people don't understand is that it's not just for restorative. Skilled therapy may also be required to maintain and prevent or slow further decline. I still hear it all the time, and I don't know if you guys hear it or not, but how many people usually hear that in order to get skilled PT or OT, there has to be improvement, that we have to discharge them if there is, if they're not making improvement. Anyone still hearing this? So we still fight this all the time. And again, a great resource for you guys that work in healthcare, the Center for Medicare Advocacy is a great resource. They're really pushing the education and training. I've met with their attorneys. And they're really trying to get out there that people shouldn't be discharged if they need it to maintain. Now, there's a whole, like, I can't just see someone to maintain their functional abilities if they could actually carry on that home program or they have a caregiver to do it. But again, a lot of our clients, we're there with them long term, right? We're not in there for a short time and discharging them. We might discharge them down to one time a month, but we're not gonna just discharge because they're making progress. And again, it's all individually, and we have to support that there is a skill need, there is a medical necessity. There's a lot of things to go, but just so you guys know that it is not true. Go to the Center for Medicare Advocacy, especially if you work in skilled nursing, if you work in home health. Lots of good information for home health agencies, skilled nursing on those requirements and so forth with that. Keep moving this little slide around so I can see talking about here. Okay, let's see. I think I covered everything on that screen. Now, unfortunately, like with home health companies, if they do keep clients on long term, it can impact what other services they can get. So if someone is on home health under Medicare Part A, they can't get outpatient in the home, or they would have to private pay for outpatient in the home. And we might not want a home health company to keep someone on long term if they're not providing them with the level of services that's really able to keep them, at their optimal level and so forth. So there's things that come into play with that. Ideally, home health should really serve as a transitional support system, bridging hospital and skilled nursing facility discharges. And then once a patient no longer meets the homebound criteria, they can be transitioned to outpatient in the home. Again, it's all about what's best for the client. I mean, if they would better be served at an outpatient clinic, we want them to get to that outpatient clinic, right? If we want them, if they would be served in the home, we want them to get that services in the home. Yeah, Medicare Advantage plans, that's a whole nother ball game, right? And story we need to talk about. So again, just general overview, outpatient in the home. It's usually under Medicare Part B. If someone has traditional Medicare Part B, it pays for 80%. If they have a Medigap plan like Blue Cross or, Sanford, they often pay for the 20%. If someone has a Medicare Advantage plan, they often have a copay or co-insurance and so forth. There's no homebound requirements. We can see people if they qualify for skilled maintenance type therapy. Questions, does everyone feel pretty good about the difference between outpatient in the home and home health? I think hopefully we covered it well. If you have any questions, we can go over that. Now, I'm going to kind of fly through these because you guys will have the handouts. Make sure you use the updated handouts because I didn't finish the presentation till yesterday. So these are the ones that you're going to want to see. But again, when we're working with someone in the home, and we can see them in their own home and community, we can really develop a plan of care that works best for them. And we not only are working with just the patient, but we can work with the caregiver as well. So we really become almost like a care coordinator, and we work with all of the different health care professionals and bring things together. So instead of seeing the primary care provider, 60 minutes a year, we might see them 60 minutes twice a week, or maybe we see them an hour once a month. It all depends on the person, but we can be in there to make sure that we're providing the care that matters most for them and connect them with the additional services that they need, to meet their goals. And then mobility, being able to work on mobility in the home is huge because it's actual real life, right? And I do want to stress that it's not just about mobility in the home or right outside of the home. We also really need to look at the community. I've been lucky enough to work with a group that is actually worldwide on a assessment looking at activities outside the home and how that really impacts our older adults in being able to age in the right place. Because just because their home is great, but if they can't get out and interact and get to the places in the community they need, it might not be the best place, especially with all the research, showing the social isolation, the loneliness, and all that kind of stuff with that. So we look at how we can get them outside of their home as well. Mentation is huge. We talked about people with mild cognitive impairment not getting assessed. That's the great thing about working with a practice that is in the home, seeing these clients. Being an age-friendly practice, we have a protocol that we have to follow. So every patient gets a screen. Based on how they score on that, depends what we do with them next. So then we do more of a full assessment. Then depending on there, maybe we'll implement cognitive stimulation therapy, or we'll implement the Skills to Care program. There's just a lot of things that we can do. So instead of us putting all this pressure on primary care providers to do all of these assessments, utilizing the different resources in the community can help, where we can identify some of these things and provide the treatment that they need. And then medications. So again, a lot of you said this when we talked about medications. We need the physician, we need the pharmacist, but they don't see what goes on in the home. And when we're in the home, we can see what truly is going on. We can see that pile of medication packs that has never been opened, or, the confusion of what one pill is versus the other. So we can really help work together and coordinate care. Like we'll do telehealth sessions with the pharmacist. We'll do co-visits with the primary care provider to help make sure that we get those medications so the clients, the caregivers know what they're taking them appropriately, and all of that. Multi-complexity. So with this fifth M, again, being in the home in an outpatient model just gives us a lot more flexibility than what home health can do, because, we can be in there more visits, longer, and can really help with, all of the different areas that come into play, and kind of like that care coordination that I talked about. This is just a summary breaking it all down. And then just to give you some assessment and intervention ideas so we can get to our case study. Medication management. I just want to let you know that occupational therapy professionals actually, there's research to support it, are a great resource for medication management. We utilize an assessment called the Home RX, which again has been shown by research to help, identify barriers to medication management, helps guide our intervention and so forth with that. So if you are seeing clients that are really struggling with medication management, getting an OT in there, they can do the assessment, they can work on intervention and coordinate care with the pharmacist, the physician, the nurses, social workers to all get them going on an appropriate plan. This just talks about some of the actual interventions that people can use. And I already told you some examples of what we do. Research studies supporting it. Mentation, again, this is a huge one. very passionate about this. I have family history of cognitive impairment, not diagnosed appropriately. There's a huge line to get into neuropsych, right? If we can get in there sooner and do these screenings and then further assessments, then we can send, the most appropriate people to neuropsych that need it. We can work with the physicians and other healthcare professionals to make sure they're getting the services that they need sooner than later. Mentation. I already talked about cognitive stimulation therapy. I don't know if any of you guys have heard about cognitive stimulation therapy. Great research to support it. We have cognitive stimulation therapy groups here in Grand Forks. We could do individual. If you guys are really interested in cognition, dementia, I'd encourage you to research cognitive stimulation therapy. They do intervention and treatment out of St. Louis University. HomeRx is an assessment that we do. And in the reference section, there's articles that detail what the HomeRx is. They're also out of St. Louis University. Mentation is we utilize the Skills to Care program. It's a great program for caregivers. We keep seeing support groups and education being provided for caregivers. Is that what they really need? Or do they need someone to come in there, do a caregiver assessment, figure out what's really going on, and create an individualized plan where we can help them be confident about handling the challenging behaviors that end up coming. Okay. Sorry, I knew I all of a sudden fast forwarded there, probably on some of the most important stuff. So I wanted to at least get to this case study. So I'm going to go through this case study, and then we'll look at, what you guys think would be the best plan for this client. So this is a male between 64, 67, experienced a intracerebral hemorrhage while with family in a remote location, had sudden limb weakness, slurred speech, actually was helicoptered into a hospital, had surgery, and then was in a rehab for 28 days. At 28 days, he had to be discharged somewhere. He couldn't stay in the rehab any longer. At that time, he still had flaccid upper extremity, significant right side weakness, expressive aphasia, required 24-hour supervision, hand-on-hand assist for all ADLs and transfers, high fall risk, reports pain in the right lower extremity, dependent in everything. Home environment, lives on a farm with spouse and primary caregiver, rural location, not really close to, immediate healthcare access, did have adult children around, steps, 3 to 5 steps on one area, 3 steps in another area, bathrooms, had a tub shower, not a walk-in shower because the other shower had a 4-inch threshold, both toilets were low, no bedroom on the main level. Prior level of function, independent farmer, very physically active, independent, active with family, grandchildren, medical considerations. This person never really has believed in medications, wanted to stay off medications, only medication, only on the one medication, and so forth. So, based off of this scenario, this information, what do you feel is the most appropriate next level of care for this client, and why? And I don't know if, since this is the first presentation of the ECHO I've done in a long time, I don't know if you guys discuss this verbally or if you share in the chat, but and also what healthcare professionals do you think need to be involved with this client? Believe it or not, we took him home with outpatient therapy in the home. Home health, they tried home health first. Home health wouldn't provide the level of therapy that this client needed. So the family said that's not an opportunity for them. He was supposed to go to a transitional care unit. So I didn't get pulled into this until later. So I'll give you a little background. He was supposed to go to a transitional care unit in a skilled nursing facility, one that I've worked at, great facility, so forth. He didn't want to do that. Family didn't want him to do that. Again, the home health just wasn't an option because he wasn't going to get the level of therapy he needed, yet he didn't want to go into the transitional care unit where, they thought that it would be best. We actually, so someone that knows what we do reached out to me. We worked with the rehab, we worked with the family, the physicians, everyone involved. We took him home. And I wish I could have data to share with you guys to compare like this situation with a rehab, but I'm a farm girl. I grew up on a small farm in South Dakota. I know this would be the same case with my dad, but I really don't think he would have done as good as he did with us if he had gone to a facility with his history and, everything I know, because he would have really been probably severely depressed. So we were able to get him home. We started with PT and OT 5 days a week. We worked with non-medical home care agencies and we worked with our state. So again, our state has some amazing programs. I'm sure other states that you guys are in have amazing programs. We work with the state to get them on some programs that help pay for some caregiving services. And we were able to see him in the home. And I just want to go through, I know time is up, real quick. When we talk about what matters, he is an active farmer whose identity, motivation, and emotional well-being are tied to being at home. He was so much better at home than even he was at the rehab per family report, that he just developed, improvement just being at home versus in the rehab. Facility placement would have likely led to depression and rapid decline. When he was at home, we were able to get him involved in routines. We were able to tie in things that, we would use a wheelbarrow for therapy. We eventually worked towards getting him into a tractor, getting him into a combine. We actually had the president of AOTA come to us here in Grand Forks and actually went out to visit this person. Because again, it just really shows that if we can get people home in their own environment, that it can work. But this isn't going to work for everyone. I mean, there's a lot of dynamics that we need to, consider in order for it to work. Mentation, again, as soon as he got home, his emotional stability improved. He had more family there. He was around people. His communication actually improved. Let's see here. Mobility, again, we were doing sessions out in the shop. We were doing sessions in the garden. Think about working on your mobility in a therapy gym versus a garden where you're trying to manure over the dirt and what's planted and so forth. Medication was pretty easy with this one because he refused to take medications, but we still work closely with the physician and pharmacist on medication management. And then complexity. Again, as all of you guys mentioned, I mean, this patient on paper, I mean, even myself wouldn't have recommended what we ended up doing because TCU, then home, right, with us. But it worked, and it worked really well. And, this was several years ago. We continue to come in as needed. I actually was recalled out to visit because now the caregiver is going to be out for 4 to 5 weeks. So now we're working on a plan to help support this person when the caregiver's out. I will tell you, he drives a combine, he drives a tractor, he drives a Ranger, he is doing really well. So that's where I'm trying to encourage you all that we need to think above and beyond traditional healthcare, because the traditional models that we've all been used to, there might be other things that would work better for people if we can all work better together, because this wouldn't have happened if the rehab didn't work with us, if the physician didn't work with us, if the non-medical home care providers didn't work with us. You know, everyone had to come together to work together as a team with that.